Can start. Hello, good morning, everybody. Um, there is less people than yesterday. I hope there's going to be somebody left at the end of the week, my lecture. So today we're going to talk about the heart anatomy. Um, the basic stuff. I have about 60 slides, so we'll try to go through them in an hour. Uh, so the heart is a very efficient pump. Uh, it beats about 2.5 billion times in average life, and it has to pump the blood through the 120 kilometers of the blood vessels. The left ventricle, the left side. Uh, the right side pumps blood through the lungs to uh, get the new oxygen at the oxygen exchange, in the alveoli, and unload the carbon dioxide. Um, so the heart is located in the uh, anterior mediastinum, which is the space between the lungs, and it rests on the diaphragm. So the lower portion of the heart, we'll talk about it, sits on the diaphragmatic surface. Um, it's a small organ. It's a very efficient but small pump. It measures about 12 centimeters, 5 inches, uh, 9 centimeters wide, and 6 centimeters thick. And you should remember average weight or mass in women, it's about 250 grams. In men, it's about 300 grams. Um, so we talked about the mediastinum. Uh, Mediastinum extends from the uh, spine, from the vertebral column to the sternal part of the chest. So throughout the whole chest cavity, and now you can see. Uh, Hello. L. Yeah. So the heart is located more towards the left side. I have to. It's located toward the. It's shaped inferiorly and towards the left side of the chest cavity. Now let's talk about the relations of the heart to the other organs. Um, so on the top superiorly there is an aorta and superior vena cava. Superior vena cava carries blood from the head and from the upper extremities back to the heart. Uh, the heart sits on the diaphragm. The lower portion of the heart sits on the diaphragm. Up front there are ribs and with the intercostal space and the sternum area. And in the back, behind the heart, is esophagus, trachea, bronchi, and descending aorta. Inferior vena cava, which is the big vein that carries the blood from the lower extremities and from the abdominal cavity and the vertebra. And based on the side of the heart is their lungs. It's important clinically. The esophagus, which lies posteriorly. Uh, we do in cardiology, we do specific tests like transesophageal echocardiogram, which is the ultrasound of the heart, and we basically insert the probe through the mouth to the stomach, and we can image the heart from the stomach and from the esophagus because it lies posteriorly and just next to the heart. So we can get much better images of the heart from the esophagus by using transesophageal echocardiogram, especially when we want to focus on specific smaller parts of the heart like cardiac valves. So that's important. Um, we can skip this. We talked about it. Um, so the apex of the heart, which is the tip, um, it's formed by the left ventricle. In normal hearts, the apex is formed by the left ventricle, not the right ventricle. So, and it's directed, as I mentioned, anteriorly and inferiorly towards the left. Um, the base of the heart is the back side, and it's formed by the atria, which are the upper chambers. It's more superiorly. And here are the heart borders. Uh, you should learn these borders because when you read the chest X-rays, which is the main imaging modality, uh, you have to focus and see the heart borders compared to the lungs and other organs in the chest cavity. So the right border, which is this part, it's formed by the, what is this structure here? Hmm? It's the right atrium. So right border is formed by the right atrium, and when I this is the right border here, and it extends from the superior portion down to close to the diaphragm. So this is part of the right atrium. The lower border or inferior border is formed by the right ventricle. I'll show you. This is the right ventricle here. So the inferior border is the right ventricle, and part of the inferior border on the left side is the apex of the left ventricle. So right atrium is the right border. The inferior border is mainly formed by the right ventricle and part of the left ventricle. The left border is formed by the left ventricle and part of the left atrial, uh, which is called auricle or left atrial appendage. So this is the left border of the heart, which is the left ventricle, and then there is a left atrial appendage or part of the left atrium. So that's the left border, and then the top or superior border of the heart is formed by the uh, roof of the atria. So this is the superior border. Is that clear? So right atrium, right ventricle, part of the left ventricle. Left border is mostly the left ventricle. On the top, there is a left atrium or auricle of the left atrium. And then the superior border is the left and right atrium. And this is what you can see on the X-ray. Now this is pathological X-ray. There is some fluid uh, in the chest cavity called pleural effusion, uh, which can obscure the border of the heart. So, but this looks like physiological normal size heart. And again, there is a right atrium, then there is a right ventricle here on the lower portion, part of the left ventricle apex, left ventricle, and left atrium. Now let's talk about the sulci of the heart, which are the anatomical structures um, on the outer surface on the heart, like little grooves that are important because they carry the arteries and veins that supply the heart muscle. There are three main sulci. One is the atrioventricular sulcus, which is between the um atria and the ventricle, right and left atrium, and right and left ventricles. Uh, and then on the front portion, there is the anterior interventricular sulcus, and on the lower portion or inferior portion, there is a posterior interventricular sulcus. Um, so these are uh, this is the atrioventricular sulcus on the right side of the heart, and on the other side, on the left side, there is a, it basically encircles the whole, the whole heart between the uh, atria and the ventricles. And anterior interventricular sulcus, and this is the lower portion of the heart, that sits on the diaphragm. This is the posterior interventricular sulcus. So AV sulcus separates atria from the ventricles, and it contains coronary arteries. There is a right coronary artery, which is we're going to talk about the coronary anatomy in a little bit, but right coronary artery, and there is part of the left coronary system, which is this left circumflex artery. The anterior interventricular sulcus carries or contains the uh, left anterior descending artery, um, and great cardiac vein, and the posterior interventricular sulcus uh, has posterior interventricular artery or posterior descending artery and middle cardiac vein. I will show you pictures again in more detail. So let's talk about the surface of the heart. I know there is a lot of. Have you done anatomy? You did, right? So this is more just the review, specifically on the heart. So I don't think we need to go through all these structures, but uh, uh, you should remember at least the location of these structures uh, in comparison to the heart. The right ventricle, we talked about it. Uh, there is a pulmonary artery which divides into the left and right. This is a main pulmonary artery or pulmonary trunk, divides into the left and right pulmonary artery, and it's anteriorly to the aorta. The aorta with aortic arch and the branch vessels that carry the blood to the brain, to the head, and neck and head. And then there is a superior vena cava and inferior vena cava that carries the blood to the right atrium. And this is the auricle of the right atrium, and this is the auricle or appendage of the left atrium. Clinically, it's important, especially the left atrial appendage, um, in patients who have arrhythmia, who had atrial fibrillation. We talked about yesterday, the blood not flowing well. If they have atrial fibrillation, the blood basically swirls in this left atrial appendage, and it's the main source of blood clots, forming of blood clots in the left atrial appendage, which can cause cardioembolization and mainly stroke. And the right atrial auricle, the clinical importance is when we implant devices like pacemakers, we implant the atrial lead to the roof of the right atrium or right atrial auricle. So we talked about it briefly. Um, Now this is the lower portion of the heart, and these are the four main pulmonary veins that carry oxygenated blood to the left atrium. And again, uh, inferior vena cava, superior vena cava, and this is the pulmonary artery and aorta from the uh, from the um, from the view from the inferior view. Now, cover of the heart, pericardium. You you all probably know that there are two main parts of the pericardium, which is the fibrous pericardium and serous pericardium. Fibrous pericardium is it's not elastic. It's like tough connective tissue that basically the function of that fibrous, it's the outer portion. Uh, it prevents the overstretching of the heart, and to some degree it protects the heart in the chest cavity. So that's the fibrous. And then the serous pericardium, which consists of two layers. which is the parietal and visceral layer. Uh, it's the outer layer, the parietal, is fused with the fibrous pericardium. The visceral layer is the layer that sits on the surface of the heart, and it's called also epicardium. And um, it basically there is a space between the parietal and visceral layer, which contains uh, fluid, right? Pericardial fluid. Because the heart moves in the chest cavity, it has to move all the time to pump the blood. We'll talk about the physiology of the heart, I think, on Thursday. So there must be some lubrication so the heart can move within the chest cavity. So, and so there is a physiologically some pericardial fluid between the parietal and visceral pericardium. Um, so again, this is the two layers of the serous pericardium, and that contain the pericardial fluid. Uh, we can skip this. Again, this is a slice of the layers of the hard wall. Uh, we didn't talk about the outer the layer, which is the adipose tissue. There is a fat on top of the heart, uh, and then there is a fibrous pericardium, and then the serous, which is the parietal and visceral and pericardial cavity. uh, so there is a just right below the epicardium, there is a myocardial tissue, which is the main function of the heart. Pumping, the squeezing the blood, pumping the blood to the body. And then the endocardium, which is formed from the endothelial cells. Uh, it's the surface that is in contact with blood inside the heart. So let's talk briefly about the myocardium, which is formed by the muscle fibers, which are connected and bundled uh, with the endomysium and perimysium. Uh, the cardiac fibers are organized in different anatomical um, um, layers, and I'll show you here. For the most efficient pumping function, uh, there are like circular layers of the myocardium, and then there are some other spiral layers. So the heart basically can move more efficiently during the systole. Um, and endocardium or endothelium. Uh, it's the inner portion of the heart, uh, and it's a continuous with the endothelium of the veins and arteries. Chambers. How many chambers do we have? Four, right? We talked about, yeah, ventricles, two ventricles and two atria. Um, Here are the heart chambers. Uh, this is the left ventricle, which is that has the thicker wall because it has to pump the blood to the body against the blood and certain blood pressure. So the myocardium is thicker. The right ventricle, which has like crescent shape, uh, the right atrium and the left atrium here. We'll talk about the heart valves in a little bit. Uh, So the thinnest portion of the heart is the right atrium. Um, Left atrium is a little bit thicker, but the thinnest portion is the left atrium, uh, 2 to 3 millimeters in the thickness. Um, the posterior wall of the left atrium is smooth, and um, the anterior wall is rough. It's formed by the pectinate muscles. There is a septum right between the atrium and between the left and right atrium, which is called interatrial septum, um, which has in the middle, little thin layer called fossa ovalis. It's important clinically when we do different cardiac procedures. We, if we want to get to the left side of the heart, we do transeptal puncture, and when we put a catheter through this thinner layer of the interatrial septum called fossa ovalis. Um, Here is the interatrial septum with with a thin layer of fossa ovalis in the middle. All right, let's talk about the tricuspid valve. Where is it? Where is the tricuspid valve? Between what chambers? So yes, how many cusps? 4, 5, 3, right? Tricuspid valve. So it has 3 cusps. Um um there are chordae tendinae that are attached to the cusps and basically connect the cusp to the papillary muscles. So this is the papillary muscle of the tricuspid valve. These fibrous filamentous structures called chordae tendinae, which connect to the cusps of the valve. And the main function is basically opening and closing the cusps. So that was the tricuspid valve. Right ventricle, I mentioned Christian shape. There is the thickness is about 4 to 5 millimeters, the muscular thickness of the right ventricle. So it's a little thicker than the right atrium, but much thinner than the left ventricle. Um, and it's more trabeculated structure inside the left ventricle. Left ventricle is more smooth. It contains papillary muscles, but in the right ventricle there are these trabeculation structures called trabeculae carneae. So when we read and see the echocardiogram and we look at we can say which ventricle is, if it's right ventricle or left ventricle. We can recognize it also by the shape, because there is more trabeculation in the right ventricle compared to the left ventricle. So the function of the right ventricle, it pumps the blood to the pulmonary vasculature, right? The oxygenated blood to the pulmonary artery. Here is the tricuspid valve, which has the 3 cusps: anterior cusp, septal, which sits close to the interventricular septum, and the posterior cusp. Again, chordae tendinae, that's filamentous structures that are connected to the uh, 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 papillary muscles of the tricuspid valve. Now we'll talk about the left atrium. It's about the same thickness I mentioned. It may be a little bit thicker uh, than the right atrium, but generally the thickness is about the same. Um, there are 4 pulmonary veins that carry the blood, oxygenated blood, from the pulmonary vasculature to the left atrium, left and right upper and lower pulmonary veins. Uh, and between the left atrium and the left ventricle, there is a mitral valve, which is the bicuspid valve. Is the only valve that has 2 cusps, anterior and posterior cusp. Left atrium again. This is the fossa ovalis from the left side of the heart. And mitral valve, again, similar structure. It has cusps anterior and posterior, or anterior and posterior leaflet, and chordae tendinae with which attach the cusp to the papillary muscles. Thickest chamber of the heart, left ventricle. Usually the thickness, or generally it's between 10 to 12 millimeters. Um, uh, the function of the left ventricle pumps the blood through the aortic valve when the aortic valve is open. And again, we'll talk about the physiology on Thursday to the body. Um, I can skip this one here. Um, I have comparison between the chambers of the heart. I think we can skip it. This is more physiology, which we'll talk about on Thursday. So these are the valves of the heart, the anatomically located. The pulmonary valve, which has three cusps, the aortic valve, again three cusps, uh, tricuspid and mitral valve between the heart chambers, uh, left and right, atrium and ventricle. We talked briefly about the tricuspid valve. Posteriorly flat, septally flat, and anteriorly flat. Let's talk about the mitral valve. So mitral valve is, I would say, more important than the tricuspid valve. Actually, patients can live without the tricuspid valve. Sometimes patients who have uh, endocarditis, they've developed recurrent endocarditis and they have damaged tricuspid valve. Uh, one of the treatment is to excise or remove the tricuspid valve, and patients can survive. Without the mitral valve, you cannot, the heart basically fails. So there are two cusps or two leaflets, which is the anterior and posterior leaflet. Uh, the anterior leaflet is larger, posterior leaflet is smaller, so it basically, when the valve opens and closes, the anterior leaflet uh, does the bigger movement during the systole and diastole. So this is the mitral valve again, from the side, uh, connected, the cusps connected to the papillary muscles. How many papillary muscles do we have in the left ventricle connected to the mitral valve? How are they called? And anterior or posterior, or anteromedial and posterolateral papillary muscle, right? So pulmonary valve, three cusps. Again, it's between the pulmonary artery and right ventricle. Um from the clinical standpoint, what is do you know what is the Ross procedure? The surgery, cardiac surgery called Ross procedure. It's patients who have damaged aortic valve. It's a complicated surgery, but patients who have damaged aortic valve, the surgeon basically removes the pulmonary valve and uh, uh, puts it or implants it instead of the aortic valve, and then using the homograph to create a new pulmonary valve. So pulmonary valve is I would say again, like tricuspid valve, a little bit less important in the body because you cannot live without a pulmonic valve. But if it's damaged, patients who have like pulmonic stenosis or pulmonic regurgitation, a lot of times patients can live throughout their life without needing replacement of the pulmonic valve. Um so three cusps of the pulmonary valve. Um We'll talk about the aortic valve, which is the fourth valve in the heart between the left ventricle and aorta. Uh, the importance of the valve, there are three cusps, and in the right and left coronary cusp, there are coronary arteries which carry the blood supply to the to the cardiac muscle. Um, so right coronary artery originates in the anterior aortic sinus. Left coronary artery originates in the left posterior aortic sinus. Here is the um, where are we? This is this is the aortic valve. Uh, This is the posterior coronary sinus, which has the left coronary artery, and this is the uh, anterior coronary sinus or right coronary cusp, where the right coronary artery originates. And then there is a non-coronary cusp, which has no coronary artery. So three uh, cusps of the aortic valve: left coronary cusp, right coronary cusp, and non-coronary cusp. Now let's talk about the blood supply to the heart. So there are two main arteries, right and left coronary artery. Left coronary artery divides into the uh, left anterior interventricular artery, or also called left anterior descending artery, um, and it follows in the interventricular sulcus and supplies the blood to the front portion of the heart, and a little bit to the apex, and a little bit to the side, and to the septum. Patients who have anterior wall myocardial infarction, they if they develop occlusion of this artery, uh, they basically have the most damage of the heart, because this is the artery that supplies the main uh, portion of the left ventricle and septum, so the front portion. So anterior wall myocardial infarction is caused by the occlusion, either partial or complete occlusion of the left anterior descending artery. Um, the circumflex artery is a second branch from the left main coronary artery, and supplies the left atrium and posterior wall, posterolateral or posterior wall of the left ventricle. It's a little bit smaller, and it divides into other branches, which are the marginal branches of the circumflex artery. Uh, right coronary artery. um it has two main branches, which is the right marginal artery, and this supplies the blood to the lateral right side of the myocardium. And the second part is the posterior descending or posterior interventricular artery that supplies the posterior and lower portion of the heart, the one that sits on the diaphragm. And here are the arteries. Again, uh, left anterior descending artery supplying the front portion or anterior surface of the left ventricle and the septum, and the circumflex artery that supplies the left atrium and the lateral wall or posterolateral wall of the left ventricle. Right coronary artery, which is located in the right um, sulcus, um, divides into the right marginal artery, and then posterior artery, posterior descending artery, or a posterior interventricular artery that supplies from from the Hello. So patients who come with myocardial infarction anterior wall myocardial infarction caused by occlusion of the left anterior descending artery, lateral or anterolateral infarction caused by the occlusion of the circumflex artery, and inferior infarct is caused by the occlusion of the right coronary artery. Coronary veins, they basically carry the oxygenated blood from the heart back to the right atrium via the coronary sinus. There are four main veins: the great cardiac vein, which is in the anterior interventricular sulcus; the middle cardiac vein, it's in the posterior interventricular sulcus in the lower portion of the heart; small cardiac vein, which drains the blood from the right atrium and the right ventricle; and anterior cardiac vein, which carries the blood from the right ventricle. And the anterior cardiac vein that opens directly, it doesn't go to through the coronary sinus, it opens directly into the right atrium. So these are the main cardiac or coronary veins. Here are again veins. Now, the last portion or last part of the heart is nerve supply. There are two systems that innervate the heart, right? Sympathetic system and parasympathetic system. The primary site in the brain is the medulla oblongata, which regulates the sympathetic and parasympathetic outflow to the heart and the blood vessels. What does the parasympathetic system to the heart? Slow down, decrease the heart rate. What else? Anything else? Decrease the contractility and dilates the arteries. And the sympathetic system does the opposite, right? It accelerates the heart rate. It causes vasoconstriction and increase the pumping function. So the primary sites are in the medulla oblongata, and then the hypothalamus and the higher centers modify the activity of the centers in the medullary center, especially the cardiovascular responses to the different emotions and the stress. So these are controlled by the higher centers in the hypothalamus. So this is the nerve supply. So sympathetic nervous fibers, they originate in the spinal column at the T1 and T4 level, where there is a sympathetic trunk. They directly opposes the parasympathetic system. So as I mentioned, increase the heart rate, causing more elevated heart rate called tachycardia, increased cardiac contractility, and causing vasoconstriction of the vessels. So here are the I don't know if you see it clearly, the centers, cardiac centers in the medulla oblongata. So there is a cardioacceleratory center and cardioinhibitory center, and the cranial nerve 10, which is the vagus nerve, originates here. This is the nucleus of the vagal nerve. And so that this is the parasympathetic system, uh, vagus nerve, and then parasympathetic nerve fibers going to the heart. And here are the sympathetic preganglionic fibers originating at the in the spinal column at the level of the T1 to T4, and sympathetic ganglia that again carry the sympathetic fibers to the heart. As I mentioned, the parasympathetic action, vagus nerve, cranial nerve 10, the role is innervation of the heart to decrease the heart rate, decrease the force of contraction, and dilate the coronary vessels. The parasympathetic system, the main action is around the sinoatrial node. And again, sinoatrial node is the node that is the original cardiac pacemaker, and it basically lowers the rate of the sinoatrial or sinus node. This is the last picture of the nerve system of the heart. Again, this is the left and right vagus nerve. And these are the sympathetic fibers going to the heart. So this was brief anatomy of the heart. We talked about the heart chambers, cardiac valves, the cardiac supply to the heart, and the nerve innervation of the cardiac muscle. If you have any questions, I can answer it now. I think we finished a little bit earlier. Any questions? Yes. Excuse me? The other disease that causes. Okay, yes. So there are several different diseases that can uh, 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 be caused or caused cardiac dysfunction. That was your question. So the main diseases that affect cardiac function, causing dysfunction, is it's called cardiomyopathy, and there are basically two main types. One is the ischemic cardiomyopathy. We talked about the myocardial infarction, which either patients who have big, large myocardial infarction that is not treated properly, they can develop ischemic cardiomyopathy. Normal cardiac function, which we assess by different imaging modalities, is the ejection fraction. We'll talk about it again on Thursday, but normal ejection fraction of the heart is between 55 to 65%. So cardiac dysfunction or muscular cardiac dysfunction is if patients have ejection fraction below 55%. So the patients who have ischemic cardiomyopathy, if they develop large myocardial infarction, or if they have several smaller myocardial infarctions, they can develop um, cardiac dysfunction. Usually, this is more localized, and it depends on the anatomy and the artery that is involved, that is occluded, either anterior, lateral, posterior, or inferior. So these patients have cardiac dysfunction. They have regional wall motion abnormalities, which we can see by the echocardiogram, and basically part of the heart muscle is changed, and there is a scar tissue instead of the viable myocardium. There is a scar tissue which causes ischemic cardiac dysfunction. And then there is a non-ischemic cardiomyopathy, which is much broader category, and there are multiple causes that can cause non-ischemic cardiomyopathy. And these patients have usually or generally global dysfunction of the heart. So when we either do um, cardiac MRI or echocardiogram, we can see the globally decreased cardiac function. And so these are the two main categories that is called cardiomyopathy and heart dysfunction. So ischemic and non-ischemic. Non-ischemic cardiomyopathy has different causes. Most commonly, it's the idiopathic uh, cardiomyopathy, most likely due to previous viral infection that can affect the heart function by autoimmune mechanism. But there are other causes like cardiac amyloidosis, other cardiomyopathies like hypertrophic cardiomyopathy, or infiltrative cardiomyopathy like hemochromatosis. So, and then there are other cardiac dysfunctions, which is, electrical dysfunction of the heart, which affects the electrical system. We will talk about the electrocardiograms tomorrow. So that's the electrical dysfunction. But the muscular dysfunction is the cardiomyopathy, ischemic, non-ischemic. Sure. Why is the ischemic disease? So why is the ischemic heart? Why does it have such high mortality? Um, uh, yes. I mean, the main reason is because it's an acute event. Uh, it's acute event, and uh, if uh, if patients develop acute occlusion of the main artery, which is the most commonly, as I mentioned, was that left anterior descending artery, uh, it basically can present in a lot of patients sudden cardiac death. So when patients develop acute occlusion, they present with sudden cardiac death. They usually don't survive. Even if they survive the initial portion, they get defibrillated. Uh, they usually don't survive or leave the hospital. So that's one thing. It's acute event. The second part is we patients who come with acute myocardial infarction, we try to treat them as soon as possible. Usually, once it's acceptable, they should get revascularization or balloon angioplasty and stent implantation within 2 hours after presentation. So patients who come later for whatever reason, they either didn't think that they have heart problem, or there was not good access to the care. If they come with in the late stages of myocardial infarction, uh, we cannot uh, save part of the myocardium, and they usually develop a larger heart attack, which is very difficult to treat. Once the heart muscle is changed and there is a scar tissue, there is not too much you can do. The heart muscle doesn't regenerate. So, but compared to 50 or 60 years ago, before we had these techniques of revascularization, patients, patient heart mortality was much increased from myocardial infarction. So we made big advances in the past 20 or 30 years by educating public, people, to come to the hospital as soon as possible if they start having any symptoms, and by doing these techniques of cardiac catheterization. I remember I have we have 3 more minutes. Uh, I had one patient um, who was a school teacher or superintendent for one of the school systems, uh, and he was in his 50s, and what he did, he arranged, or he was responsible of for putting the defibrillators uh, in the school system, in the schools. And this patient one day developed chest pain, and he collapsed in the school during the school meeting. And they were able to defibrillate him. The other teachers, they did defibrillation, and they brought him to the hospital quickly. And he had occluded the main artery, the left anterior descending artery, and he underwent revascularization within like half an hour after he collapsed, and he survived without any cardiac damage. So that's the main thing, basically, that these patients need to get to the hospital as soon as possible. But if he developed cardiac arrest sometime somewhere outside on the street, he probably wouldn't be here now. Or if he didn't arrange the defibrillators to be located in a school. So again, he received stent and angioplasty within 30 to 40 minutes. And on the subsequent studies, either the stress test or echocardiogram, he has no heart damage. So the sooner patients get to the hospital, the higher chance they survive, and they have less late complications of the mechanical complications from myocardial infarction. Any other questions? Yes. Not without the I said the pulmonary valve is not as important, that if there is some, unless it's very severe dysfunction, that patients uh, can tolerate dysfunction of the pulmonary valve, but they can survive without the tricuspid valve. Here, the tricuspid valve. So there is basically between the right atrium and right ventricle, there is a continuous blood flow. If there is no tricuspid valve, there is a continuous blood flow, and the blood flows from the right atrium to the right ventricle, which then pumps the blood to the pulmonary vasculature. So there is an increased blood flow, but if patients have normal right ventricle, it causes a little bit enlargement of the right ventricle and some right ventricular hypertrophy, because there is continuous blood flow from the superior and inferior vena cava. But if patients have or start with normal right ventricle, the right ventricle is able to take all the increased blood flow and pump the blood to the pulmonary vasculature, which is low pressure vasculature. So there is a little bit less work on that right ventricle. The left ventricle couldn't do it. The left ventricle would fail. It couldn't pump all the blood that continuously comes to the left ventricle to the body, because there is a higher pressure system in the body, and the left ventricle has to work much harder. So the right ventricle adapts. It adapts by some dilation and hypertrophy, but it is able to pump the blood without the tricuspid valve. Anything else? Any other questions? Yes. Yes, we will talk about the valvular heart disease on Friday, but generally, the mechanical valves compared to the bioprosthetic valves are more durable. They last longer. Uh, the disadvantage of the mechanical valves is that they need the patients need to be anticoagulated. They need a lifelong anticoagulation. So just the most simple way um, to make decision is in younger patients we implant more mechanical valves because they last longer. Patients don't need the reoperation. I have some patients who have mechanical valve for 30, 35 years and just one valve and they are still doing well. But they need to realize that they have to be on anticoagulation, and the only treatment, we talked about anticoagulation yesterday, is the warfarin. The other new anticoagulants, they didn't show any, there was increased thrombosis in patients who have mechanical valves. So they need to be on Coumadin with constant measurement of the INR. But again, in the young patients, it's preferable because they are more durable. The bioprosthetic valve we usually implant in older patients, usually patients who are over 60 or 65 years old. The durability of the new valves, new bioprosthetic valve is longer. In the past, it was about 10 years. Now we learned from the new bioprosthetic valves that are either implanted surgically or transcutaneously, called TAVR procedure, that these valves, they don't last as long as the mechanical valves, but they last longer than general, longer than 10 years. So younger patients, usually they get mechanical valve. The older patients, they get bioprosthetic valve. But again, when we discuss these issues with the patients, we give them all the options, and it has to be shared decision between the doctor, surgeon, and the patient. That's it. All right, thank you. Tomorrow we'll have fun. We'll do EKGs.